Guantanamera, Guajira Guantanamera, Guantanamera, Guajira Guantanamera. Yo soy un hombre sincero.
So let's begin by talking about this. The disease we're going to be talking about today is called reflex sympathetic dystrophy. That's the old name. Everybody wants to talk about complex regional pain syndrome. The same thing. But let's talk basically about that disease and remind you, and by the way, if I'm speaking too fast, Umberto, go like this, okay? Slow down. Despacio, okay? There are other disease states that are similar. A big one is fibromyalgia. Another one, which isn't pain, but it's pain up here. Mucho dinero. Depression. Intractable depression. That means it's worse than pain in a way because the lights never come on. It's dark all the time in the brain. Okay? And we know ketamine can be very effective in that situation as well. But we're going to focus today on the complex regional pain syndrome. Okay? Now, what we're going to focus in on is what we call how to measure pain. Because, you know, everybody's, oh, it's subjective. Yeah. How can we rely on that? If I come to Umberto, he has a big white coat on, and he looks like a professor, and he does look like a professor. Make sure you get a picture of him. Over there, Professor Umberto. That the patients, they don't want to tell you the bad news, usually. They want to tell you, you know, I came all the way from the United States to Cuba to get my pain treatment and it didn't work. No, they don't want to do that. So what we try to do at the foundation is try to base everything on objective analysis in terms of pain, and also don't forget, with pain you have dysfunction, range of motion, strength, and all those sorts of things. So what we want to focus in on today is how to measure this pain objectively. That's going to be our focus, okay? So the first thing I need to tell you is just briefly, not in detail, I need to tell you about what is this complex regional pain syndrome, okay? You have to remember that it's a clinical diagnosis. What do I mean? There's no laboratory test for it. There is no laboratory test. So, but you can get a pretty objective picture if you're dealing with RSD, if you have the right tools. For example, let's talk about the clinical history. When do you think you have RSD? It's when there's three criteria. Well, number one, when the injury does not follow the normal healing course. For example, if you get a sprained thumb, you expect within a week the swelling's going down, the pain's decreasing. But if the pain is increasing, and especially if it turns to more like a burning pain, then you have to think maybe RSD. And if the pain is spreading, now it's going up the arm, into the face, or into the legs, the patient is either crazy or they have RSD. So now you get into one of the challenges of dealing with this disease, because some of the symptomatology, the symptoms, what the patient describes, sound like they're crazy. So you, as a good doctor, you have to be able to distinguish between the emotional symptoms and the real disease state. Right. So one of the things that helps a lot is that when you develop RSD, it involves the sympathetic nervous system. So the second criteria, besides the fact that it doesn't follow the normal healing course, is that there's abnormal function of the sympathetic nervous system. And as you know, as doctors, is that the sympathetic nervous system controls blood flow. For example, to the skin. You get an injury, you're walking along, you step on some glass, it's an emergency, your sympathetic nervous system is activated, so the blood vessels in your skin contract, so you don't spill blood all over the place. If you're in Cuba and the police are chasing you down the street, your sympathetic nervous system is up, so more blood goes into your legs, so you can run faster than the police, right? Same thing in the United States. We have the same thing. So it's an emergency response, okay? What does that mean? That means that normally it happens on both sides. You step on glass with your right foot, your left foot also contracts. With RSD, what happens, it becomes asymmetrical. Very important concept. So the right leg may be colder, it may be warmer, it could be either way, but it's not the same on both sides. That's why measuring temperature, like with this infrared scanner, which I'm showing you here, is important. So, for example, if we take Alberto here and we measure...
I just died.
No, you're still alive. You're 33.5. But Alberto, I got some bad news for you. Your temperature is decreasing. You're slowly dying.
I cannot listen my heart stops.
So this is a valuable tool. Again, it's objective. It's an objective measurement that you can make. Okay. So you're looking for those things like temperature changes. Sweating is another thing asymmetrically that can happen with the sympathetic nervous system. They're sweating on one side than the other. It could be, swelling more on one side that doesn't go away after a week or so. So all of these things, as a good doctor, you're looking for to say there's some asymmetrical changes that show abnormal function of the sympathetic nervous system. The third criteria that's important, and by the way, everything I'm telling you is documented in the scientific literature, is that you have to rule out other possible explanations. So, for example, and RSD is far more common in women than men, about 60-40. In adults. In children, it's far more common. Like little girls get it far more common than little boys. Let's put it this way. The important thing is to be able to look for the asymmetry between the two sides of the body. And when you see that, you know you're probably not dealing with something like rheumatoid arthritis. On the other hand, if a woman comes in and says, my hand is cold out here, it can be cold because you got a breast cancer. So you have to be able to do a good differential diagnosis. That's the bottom line. All right, so let's stop talking about the diagnosis. Let's talk now about how do you measure RSD objectively in terms of clinical outcome. The challenge is that pain is a perception. Studies show that, for example, some cultures are cry easier than other cry. They complain more than others. Gender and so forth and so on. But we can measure, especially for things like RSD, we can measure it objectively. Well, how do we do that? How do we do that? We know that what happens when we get this RSD to pain, your whole body, especially in the area where it's been injured and has spread, is far more sensitive to pressure. So they say ouch when you squeeze their fingers sooner than others. Well, take advantage of that. So you can take a device which looks like this, okay? And we put pressure on the skin. So I think Alberto was asking me earlier, well, how accurate is this? How precise, more importantly, how precise is it? There's a difference between accuracy and precision, isn't there? Okay. So how precise is this? Can I go up to Alberto and do a test? We haven't done this before, have we, Alberto? Have we?
No.
So this is me approaching you without having ever, and I have to use my glasses for it. Oh, here they are, right here. So I can read these numbers.
Your eyes.
So we're going to see how precise this is, right? We haven't done you before. All right, so we're going to get your thumb up here. Or did we? We never did this before, did we? Okay, so what you're going to do when the pressure sensation turns to pain, and you're not going to look at the numbers, you're going to say, stop, para.
Yeah.
¿Entiende?
Cancel carajo. Coño.
Are you ready? We'll do a practice one first so you get the idea.
Go ahead.
This is a practice one. So you say stop when the pressure turns to pain, okay? I'm going to do another one for practice. Here we go, so you get the idea.
Yeah.
You say, that's stop, right?
Stop.
Okay, so now we're going to repeat it. This is the real thing. You ready?
Yeah, but that to
Rub your finger.
Let me relieve myself. because it's paining now.
Freshen your fingers up, right?
Okay.
You ready?
Yeah, go ahead.
Let's do it. Okay, say stop when the pressure turns to pain.
Okay.
Okay, so that was, so everybody knows that was a 3-5, right?
3-5.
Now we do it again.
Okay.
What's that number?
3.5.
3.5, right. You ready for the last one? Always do 3.
Okay.
Humberto, what is that number?
No, let's, oh, 3.5.
3.5. Now that's what we call precision.
Mm-hmm.
Okay?
Precision.
Don't say accurate, but it's precision. It's reproducible.
That is pain the whole.
May I?
Sure, of course. Oh yeah, of course.
Okay.
This is what we call being a control. We're doing a randomized, multi-center study. You're on the other part of it. You say stop. I have to do a couple of practice so you know what I'm talking about, okay? So when pressure turns to pain, we call that a pain threshold. You're going to say stop. Okay, here it goes. This is a practice one.
Yes.
Okay, now you ready for the real thing? Okay, here it goes.
Yes.
Okay, what's that number? 325, would you say?
3, 5, 6, 7.
Probably about 325, approximately, right?
Yeah, approximately, yeah.
Okay, here we go, and here's another one.
Yes.
What's that number? 3.5, right?
A little bit more. 4, yeah.
3.5, approximately?
Yeah, 3-5, yes.
Okay,
Yes, yes.
uno más.
3-5.
Yes.
So that's approximately about 325, 3.5.
Yes, yes.
So what does that mean?
Yeah, that's
That
it.
means he's a bigger baby than you are.
Yeah.
You can handle more pain.
Yeah. I said the whole school.
Okay, so the
You know
point,
why, you know why?
the point I want to make, if you look at this in terms of scientific measurements, that's pretty damn precise, okay? So this is a valuable tool. Let me give you an example of what happens to a patient. Now we're going to record on this thing here. If I turn it on, how about if I turn it on? I think that'd be a good idea. This is her left side. This is how much pressure was required before we treated her for 4 days of ketamine. After 4 days of ketamine, look, she's off the scale.
Up to 4, up to 5, 4.
4 days, she's off the scale. It takes far more pressure
Yeah.
on her heel to trigger the pain. And you see a similar result here for her heel. And you can see also that it's not just in her leg where she got injured, it's in her upper extremity as well. Now, what does that tell you? You just witnessed between the two of you how precise this is. You know, as a doctor, that you helped the patient. You don't know when they say, oh, Dr. Umberto, you are the greatest thing since 7-Up. You don't know. You think they're just patronizing you. But here you know. Why is that important? Because as a doctor, you want to know that you're helping the patient. If those numbers were going down, you know that you're not helping the patient. And maybe you need to rethink 2 things. One, maybe you didn't get the right diagnosis. Maybe this treatment does not work. Okay? So you as the doctor need to have the assurance to know that you're helping the patient. The patient needs to know that you're helping them. I have patients that say, Doc, my wife, I don't know if she's any better. I show them this, and they go, holy crap. I don't know, is crap a word in Spanish? You know, the patient knows that you helped them. So you can show them this, and you feel confident that you're helping the patient. Now this is just one parameter. It's just only one parameter that tells you that you're helping the patient, okay? Now we're going to move on to another parameter that's important. And that is, you have a patient come in. Now, I got it in my leg, doctor, but I can't comb my hair, I can't brush my teeth. And you think, oh God, it's in the leg. How the hell could it affect the head? So you do the pain thresholds, and you see, for example, here in her upper extremity, her pain thresholds are lower. They're abnormal, and then they get normal. And by the way, we've done normal people, and we know that what's normal and what's not, what's abnormal. Okay, so, but another way to measure independently, objectively, is movement. So the patient, I can't feed myself. So you do these measurements before, and you do it afterwards. What? Range of motion and strength. So now I'm going to show you an example of that on a video recording of what I'm talking about. And so that's what we're going to do now, assuming we're recording, and we are. So now we're going to go to the video part of this thing. So we're going to go over here to, oh, actually what we're going to do is going to close this for a minute, like this. And we're going to go back over to here. And now we're going to go to this patient. This is a young 19-year-old girl. I say it's more common in little girls, but also in women, as you know, in younger age. Probably around 20, 30 years old. So this is only I think she's 19 years old. She's a young girl. So we're going to try. And by the way, keep in mind, as a doctor, there's a certain amount of doctor-patient relationship that goes on. And what do I mean by that? These patients are scared. They've been suffering for years. And they don't know, you know, just Dr. Kirkpatrick, who's he? So one of the things you'll see here, this is how I interact with patients. Some of it's kind of goofy, like I tease them and I play with them a little bit. You get them to relax a little bit because they're scared, they're frightened, nothing's worked. And who are you? You're going to just be another one of those doctors. So keep that in mind as you watch this. This is the way I interview them. It may not work for you, but it works for me. Okay, here it goes. So we're going to do that right now. So today's January 12, 2014. Let's go over your history just a little bit. About a year and a half ago, you had an accident involving primarily that left lower extremity, okay? Mm-hmm. And no fractures were involved. Shortly thereafter, you were diagnosed with this reflex sympathetic dystrophy. And there have been several options that have been discussed, including but not limited to things like epidural injections and local injections. And we talked a lot about that, where the local injections can, if you have CRPS or complex regional pain syndrome, can actually make things worse. Okay. Mm-hmm. Now, so let's ask you a question. Now you've given this a lot of thought, right?
Yes.
So what made you come to the conclusion that this is probably the best option for you?
I didn't feel like there was any other option for me that would work as well as this would. I've tried other things like medication and no progress.
Okay.
Things have been worse.
Right. Okay, so I'm going to stop for a second and just make a comment. Okay, one of the things you want to do as a doctor, especially in the United States, I don't know how it is here, it's called informed consent.
Yeah.
You want to make sure this patient has decided to do this through thinking. She didn't come in yesterday and I decided this would. No, she came in a week before and she thought about it. And now I'm asking her to explain why she decided on this treatment. And what she's going to tell you is, doctor, look, it's not in my leg anymore. It's in my arms. It's in my face. I can't eat. I can't open my mouth or very well. And now she. So I have documented on the record with the video that she understood. In the United States, not here. Malpractice is a big problem.
Yes.
Mucho problema. So now it isn't, Dr. Kirkpatrick gave her the opportunity to be informed about what she's going in. Because remember, what I am going to do, Martha, go look at me over
You're
here.
having witness.
What I'm going to do is I'm going to give her ketamine, and basically I'm going to cut her head off. I'm going to cut her head off. There's going to be no signals going from here to the brain. She's 19 years old. And that's what ketamine does. It's called dissociative anesthesia. Okay? That's a big deal. Her father's there, her mother's there, etc. So I want to make sure that this patient understands what she's getting into. She's 19 years old, and I think in Florida, I think in Cuba it's the same as the United States. 18 is the year of consent. Am I correct?
Yeah.
18.11 months and 29 days.
Jeez, how does he know that? How does he know that?
I have to deal with that.
You have to deal with it. Yeah, that's very good, very good. Thank you. Okay, so that's why I always ask that question, and it's documented on the report. One more point I want to make. You say, well, Dr. Kirkpatrick, she's only 19 years old. Her parents are there, and they're disclosing personal health information, right?
It's a witness.
Right. And in the United States, the government, my government, considered a serious criminal offense if you disclose. They can put you in jail, they can fine you huge amounts of money if you disclose personalized health information. You're going to see in this recording later on, I say, are you okay with me using this for educational purposes? I ask the parents, I ask the mother. You'll see that later on in the recording. So that's the second point I want to make on this. When you're going to do these recordings, make sure, I don't know how it is in Cuba in terms of informed consent as far as disclosure of personalized health information, but it's extremely important in the United States, okay? All right, let's continue.
Right, right. And of course, your CRPS, as we've measured all the measurements on you, suggests it's just not in that left lower extremity. You have it throughout your whole body. And so what the ketamine does, it treats the whole body. It's not just treating that isolated part of your body. Okay, as the blocks would do, for example. Okay, now, are you ready to do some testing here so we can get a very objective picture of where you started here?
Yes.
Okay, so let's do this. I want you to do the vertical finger test. Remember how that works? You're going to take two vertical fingers in your mouth. I'm going to ask you if you have any pain in your hand when you do that. And look straight ahead. Oh, in this direction, okay? All right, get those two vertical fingers. You having any pain when you do that? Okay, point to where you're having the pain, please. Yeah, are you having it on both sides? Or just, but it's worse on the left side. Is that correct? It's sort of in the jawline, correct? Okay, next thing I want you to do, Hannah, I want you to take that right hand, put it behind your head, please, as best you can. Are you having any pain when you do that? Okay, now do the left hand behind your head, please. Any pain when you do that? Okay, I want you to take that right hand out in front of you, and I want you to open and close it as fast as you can. And are you having pain when you do that?
No.
Does it feel stiff?
Yes.
Because you can't really do that very fast, can you? Now do the same thing with the left, please, as fast as you can, okay? All right, a little faster there, aren't you? Now, are you having any pain over there when you do that?
Still in my finger a little bit.
In that area? Okay, just get above your wrist when you do that. It does get above your wrist? Does it get above your elbow when you do that?
A little bit.
A little bit? Okay, very good, excellent. All right, now the next thing I want you to just take both hands out in front of you at the same time. Open and close as fast as you can on both sides. Now, do you see the difference there, how stiff that right one is? You notice the difference there? Okay, good job. Now the next thing we're going to do, Hannah, is we're going to ask you to take that pants leg on the left side up. Previously, we marked you where we have what we call allodynia. That's where any type of tactile stimulation, especially light stroking of the skin, causes pain, like a road burn type sensation, right? So what I want you to do, Hannah, I want you to start above or just below your pants leg line there, and I want you to work your way down, and I want you to stop when you start with your eyes closed. Stop when you think it starts to feel like road burn, okay? So we can document that. Right there? Very good. You're very, very close to that line. Okay, now come down the very front of your leg there. Do the same thing. Stop when you get to the area that feels like it's like road burn. Keep your eyes closed, please. Perfect. Now do the outside aspect. There you go. Good job. Yeah. Just go on down. Stop when you think you get to it, where it is. Perfect. Good job. Now, next thing I want you to do is I want you to take that right foot off the ground, and I want you to rotate it for me, please. Atta girl. Good job. Wiggle your toes as best you can, please. That's it. Hitchhike back to Plant City. All right. Yeah, I don't know if you're going to have to get a sleeping bag. I don't think you're going to make it. All right. Now do the other side, please. Rotate your ankle over. Oh, by the way, I'm sorry. Did you have any pain when you did that?
Just a little bit.
A little bit. And where did you feel the pain when you did that?
Up my leg.
It went all the way up your leg. Is that correct?
Yes, and even
Up into your
my
hip.
a little bit.
Up into where you got your hand on your hip there. Okay, perfect. Now do the same thing for the other side, please. Rotate. Again, is that triggering pain all the way up your leg? But most intense down where your ankle is that correct?
Yes.
Okay. Now how high up did it get on this side when you did that?
Probably about the same.
About the same, up to the hip? Okay,
Yeah.
gotcha, understood. Okay, very good. Now, the next thing we're going to ask you to do is, with your dad's help, he's going to be there to spot you for safety. Yeah, go ahead and bring that down. Atta girl, good job. He's going to be there to spot you, okay? Atta girl. You're going to go over by the door there. That's it. Very, very good, very good. Remember what we talked about earlier. I don't want you to do anything that puts you at risk of falling, okay? And I don't want you torturing yourself, but I got to get an idea of what you can and cannot do. So I want you to take 3 steps forward, please, for me. 1, 2, and 3. And go on back 3 steps, please. Don't turn around, just go on, right on back. There you go. And when you get back over there, Hannah, I'm going to ask you where you had the pain, okay? Go ahead, tell me.
In my ankle, and then I felt it in my knee, and then in my hip.
And your hip, right,
Yeah,
and that
right.
left, and most intense on that left side,
Yeah.
correct? Did you have any pain at all on the right side?
Not as much as the left.
But again, it was down in the foot,
Yeah.
but it went. The pain managed to find its way all the way up into your hip on that side. Is that right? Now I want you to hold your for safety. I want you to hold your dad's hand. I want you to try as best you can to see if you can get up on your toes and take 3 steps forward. Remember what I said. Don't even try it if you can't. You can't do it without falling. Okay? As best you can. Okay. All right, I get the idea. Okay. Now the next thing we're going to do is you're going to ask you to try to do the same thing with your heels. Can you do that, please? Atta girl. There you go. As best you can. All right. One more step, and that'll be it. Okay, perfect. Now go ahead and have a seat, please. Now, Dad, one of the things you need to appreciate when I ask her to do those sorts of things, it's something like you or I. When we finish doing an exercise like that, the pain goes away. Am I correct on this? That pain is still lingering on. Am I correct on that? Yeah, it can last for hours, okay? So we try to limit the amount of torture here. All right. Now, let's talk to your dad here for a minute. Dad, you knew her before all this happened some year and a half ago. Why don't you tell me how this has impacted on her quality of life? What she was doing before and what she's doing now, please.
Well, she was doing the normal things that any 17-year-old would do before, prior to this accident that she had with her left foot. I mean, after the accident, this has been an ongoing, constant pain and battle for her. I mean, it's turned into severe. It's went from her foot to travel throughout her whole body.
Right.
She's in severe pain. She has, I guess you would say, kind of tremors or like seizure type,
Right.
spastic type.
Yeah, we talked about
Shaking
that. Sometimes
really
the pain
bad.
is so severe that this happens to you mentally. You just get frozen.
Yes, sir.
Yeah,
And,
it's a
but
normal. It's a normal body defense. Every one of us has,
Yes,
even
sir.
if we don't have RSD.
Right.
And how do we know that? And this is important because you're the parents, and you need to understand that this isn't something she has any control over.
Right. I
You
understand.
take, for example, take the Japanese prisoners. They took Americans in, and what they would do to these guys to try to get them to talk. Okay, they should take, and I hate to put it to you as bluntly as I'm going to put it to you. They should take piano wires and tie their testicles and torture them that way.
Yes, sir.
And what would happen is before the prisoners, in order to get through that, they would actually do what she did. They'd actually become paralyzed.
Yes, sir.
And that was the brain as a way of protecting themselves from overwhelming pain.
Right.
Okay. So
Right.
this is something that all of us are capable of doing. It's just a natural body response.
Right.
Animals do the same thing. You take, for example, a deer. You ever heard this? You probably maybe had it. A deer is out in the middle of the road. It's going to get run over by a truck. Now, during the day, it may not be a problem, but they get frozen on the bright lights, stimulating them so much that they just freeze right there, and
Right.
they get whacked. Okay. So this, I just want to emphasize because when we have young people in, and we see this a lot in young people, a lot that have CRPS, the parents, they're baffled. Doctors are baffled by it, and they often accuse the patient of being, a fake or
Right.
fictitious and all this kind of crap. But it's a real biological response. It's normal. It's what will happen to anybody that is in severe, extreme pain, unbearable pain.
Absolutely.
Okay, I'm sorry to interrupt you, but I wanted to make sure I got that on the record.
No, that's fine. Yeah, we recognize and know that she's been in severe pain and has
Yeah.
been for quite some time now.
Right.
And we know that it's definitely it's real.
Right,
And
right,
she's
right.
been affected by it tremendously. I mean,
Sure.
she's not able to do hardly anything.
Sure.
She's
Absolutely.
very limited on what she can do.
Sure.
She can't do any extracurricular activities,
Sure.
go out and have any kind
Sure.
of fun.
Sure. Absolutely. Absolutely. Does that pretty much tell the story here, Hannah?
Oh, yeah. I mean, even walking to my bathroom to take a shower, I need help.
Yeah. Sure.
So
Sure.
that tells you
Well, how
my
about some
limits.
water? Just touch drops of water touching that foot.
Washing,
Yeah.
Sure. Pressure of the shower.
Sure. Remember what I said. You do have it in your face, okay? Which means part of that is your hair. So you're brushing your. Some patients we have in here, they can't even shampoo their hair,
Right.
and some of them actually go ahead and just shave their head, because for hygienic reasons.
Right.
Yeah.
There's just a lot of times, she can't even stand for her clothes to be touching her hair.
Absolutely.
Her
Clothes
bed
are-
sheets and stuff.
Right.
Yeah, really.
Absolutely.
Really bothers her.
Absolutely. Now, Dad, I know you're going to watch this 12-minute video, okay?
Yes, sir.
So you'll know what goes on in the room. But at this point, do you have any questions, any concerns that you'd like to ask me?
No, sir. Not right now, I don't.
Okay. Let's see if Hannah has anything. Yeah, you have anything, Hannah? Okay.
This whole video, because we don't want to spend a lot of time. I want to focus today on objective measurements of outcome. That's critically important. So what we're going to do now is we're going to go to the next video and show you what it's like when she's under ketamine, okay? And that's what we're going to do now. Now, what do? How do we keep these patients safe? What we do is this. We want to make sure the brain is separated. We want to reboot the brain. When you have problems with your computer, Dr. Humberto, what do you do? What do you do when you can't figure out what's happening? Restart. Right. So that's what we're doing with the brain. The brain isn't any different, okay? It takes, what do they say, about half a watt to run the brain. It takes energy and it takes electricity to run the brain. So we're shutting the brain down and letting it come back up again, each time, over 4 days, okay? Repetitively, okay? Now you say, well, Dr. Kirkpatrick, are you doing this constantly? All night? No. We're shutting it down the first day. And so what you need to understand is this, is that what ketamine does, it inhibits glutamate. What the hell is glutamate? What the hell is glutamate? Well, I'll tell you what it is. If you don't have glutamate, you don't feel pain. Children born without glutamate, and you know what? They die, usually. About 5, 7, they bleed to death. They don't even know they cut themselves. People who get complex regional pain syndrome or who get fibromyalgia, the glutamate levels go up. Up. So what ketamine does is it inhibits glutamate. So therefore, it should surprise you you give ketamine and it decreases their pain while they're getting ketamine, right? Okay, but what is surprising is that the pain relief can last for months. The ketamine's gone. It's redistributed throughout the body, it's eliminated. But the pain relief can last for months. Now, here's what's important. If you give ketamine the first day, you take the glutamate levels down to here. If you don't give it the next day, it just climbs right back up again. So what we do, over 4 days, we take it down to this level the first day. Come back the next day, we take it down to here. And then we take it down to here. And then we take it down to there. That's why we don't have to put patients in coma anymore as much as we used to. And before, we just put them in coma for 5 days in intensive care unit. Mucho dinero. Muy caro. Now, not necessary. We do have some patients we have to put in a coma because they're too sick. You can't treat them outpatient. This is all done on an outpatient basis. Okay? So that's why we have to give it over 4 days. We have found through our testing that it takes about 4 days to get the glutamate levels down low enough. Okay? So now what you're going to see in this next video is what this patient is like. Now, how do we keep the patients from going into coma? Really simple. Really simple. Every 15 minutes, we ask them some questions. So, we want to make sure that they have their long-term memory. Because we don't have long-term memory when you're under a drug, you're going to go into coma. You know that as anesthesiologists, right? On the other hand, the first thing that gets knocked out is your short-term memory. Let me give you an example. I want to pick on you now. Alberto, are you ready? Can I ask you a question? What country do you live in?
Cuba.
Right. That's part of your long-term memory, right?
Yeah.
So that's burned into that disc up there.
Yeah.
I'm going to ask you another question. May I ask you another question? Yes? See. I noticed under the door there, I noticed that there's a red marble. Now, Alberto, don't look. Can I ask you a question? What did I notice under the door?
Why? Because you open the door and come in.
No. What did I notice under the... Alberto!
I don't get you.
Okay, can I ask you another question?
Yeah.
Another question. Pay attention, Alberto. I noticed that the doorknob on that door over there, don't look,
The doorknob.
the doorknob,
Yeah.
it is green. Alberto, can I ask you a question? What did I notice about the doorknob over there?
How can you know? Because you opened it?
No. Did you notice?
The
Yeah, I
color!
noticed, I noticed.
The color!
I not this green. It's not green. It's
No, well, you answered the question. The question was what color it was, and you know the answer. It was green.
It's green.
When you're under ketamine, you can't answer that question. It's not possible. It's part of your short-term memory.
Yeah.
So every 15 minutes we're
Yeah,
measuring,
sure.
and a nurse can do this. You don't have to be a doctor to ask a question and get an answer, right? All right. So we want to make sure we don't give too much ketamine, but we want to give enough to knock out long-term memory, but keep short-term, we want to get enough to knock out short-term memory, but not long-term memory. So when you're under ketamine, you should be able to answer. You should be able to answer the question, what country you live in, or who's your best friend sitting next to you, what their name is, and so forth.
But compared to saying color.
Yeah, right. Right. But if I tell you, for example, that he's wearing a red watch,
Yes.
can I ask you a question?
Yeah.
What did Tony see over there? What did he just see?
That much.
Right. We don't want you to be able to do that when you're under ketamine,
Yeah.
because we want to give you enough ketamine
Yeah.
to shut the brain down. You understand? Okay. Wait a minute. Okay, so here we go. So here goes what it's like when you're under ketamine after 4 days, okay? While you're under ketamine.
Anna, we're going to do some testing on you. Okay, so just for the record now, we're sitting here at January 16, 2015, and she's been on 135 she's been on 200 milligrams of ketamine now for a good almost an hour. So and she's on a pretty stiff dose. Her vital signs have been very stable. Breathing is great. She hasn't had any adverse hallucinations. We've had to deal with some issues with saliva on her, which doesn't surprise us given how young she is, okay? And we control that with some Robenol, but otherwise she's doing pretty good right now. So, you know this man over here? This is your dad. You see your dad over here? Look over there. Hannah?
Hannah.
Your dad has to ask you a couple questions, okay? That lip movement is typical of what we see with patients that have RSD. Okay, go ahead, Dad.
Hannah. What is your dad's name? What's your dad's name?
Chris.
What is your mom's name? What's your dog's name?
Henry.
What is your boyfriend's name?
Huh?
What is your boyfriend's name?
Huh?
What's your boyfriend's name? I said, what's your boyfriend's name?
That's short-term memory, so I can understand why she... Okay, Mary, get over there where he is. Mary's got some questions for you.
Stay here.
All right. You recognize Mary over here? You remember Mary?
Hi, Hannah.
Look over there. There's
Hannah.
Yeah, you see Mary? Mary's got some questions for you, okay?
Hannah.
Are you ready? Hannah. Mary's got some questions for you. Go ahead, Mary.
Hannah,
Hannah.
can I ask you a question? Hannah, I noticed your dad is wearing green glasses. Hannah, can I ask you a question? What did I notice about your dad?
Hannah, you need to pay attention, okay? Can you pay attention? You want to pay attention to Mary? See? Yes?
Hi, Hannah.
Hi.
Listen to Mary, okay? Listen to Mary. Go ahead, Mary.
Hannah, can I ask you a question? Hannah, can I ask you a question? Hannah, I notice your dad is wearing a pink shirt. Hannah, can I ask you a question? What did I notice about your dad?
No response?
Hannah,
No, she's giving us the information that we need, okay? She can answer the short-term things more or less, right?
Right.
But she can't really handle anything new, okay? Which is fine, okay? All right, very good. We're all set.
Okay, so what you've learned from this is she's kind of almost losing her long-term memory as well, right?
Shut up.
Huh?
She can't
Not
see.
completely. Not completely. She knew her dad's name. She knew a few things. And when you ask her a question, can I ask you a question? She says yes. So she has some left.
Yeah.
Some brain function left. Not much. Not much. If I tell her to take a deep breath, she will do the usual take a deep breath. She will do that for you. Okay?
How many hours do you do it?
4 hours each time.
So it's 800 milligrams.
Yeah. Yes. Yes. Yeah. That's a lot for us as anesthesiologists.
That's 4
But here's what you
for
have.
her is more or less 4 milligrams per kilo, which is about 50 kilograms.
Yes, that's correct. That's right. That's correct. Now you say, Tony, how come she's not under general anesthesia?
Yeah.
I'll tell you why. Because we started low and gradually worked up.
There was
It was not.
Not induction.
No, not induction. No.
Not at all.
Now
Not
the
at
other
all.
question is, why isn't she having adverse hallucinations?
Why not?
Because it's very slowly, you're saying.
Yes.
Yeah, it's very slowly.
But more important, muy importante. You notice that her father is by her bedside.
Yes.
With someone that's familiar with her long-term memory who's in the room, it's huge in preventing them to slip into an adverse hallucination. And she's not asleep. She's awake. When they have adverse hallucinations, they usually doze off. Boom! Why is it so terrifying? Imagine this. You are here at the National Hotel today. You wake up and you have a bad dream. You're at your home. You have a bad dream. Which place would you rather be if you're having, and we all do, no matter how old we are, if you're normal, we have bad dreams. And you wake up and you have this bad dream. Would you rather be at the National Hotel or would you rather be at home?
At home.
Of course, because when you wake up, oh, there's my ceiling fan. There's this.
I'm not lost.
Yeah, I'm not lost. They're not eating my legs off. Right? So it's critically important. Never, ever do high-dose ketamine without having a significant other by the bedside. And by the way, doctors, let me tell you something. It takes a lot of workload off you. Guess who's measuring her cognitive function right now? It's not me. It's the father. It's the mother. That's less work for you, right? Less work for you. It means you can do other things with your time. Okay? All right. ¿Qué pasa?
Que cuando dijiste bom, por poco se me cae la cama.
She falling asleep?
Yeah. No. She gets scared. Something's going to happen. We say, Mom, what happened here? What is happening
Por
here?
poco se me cae la cama.
Did I scare her?
That's an anecdote.
Yeah.
Okay, so. Martha. No, Martha, don't, you know, just nice, suave. Intendate suave.
Yeah.
You know, Martha, you know, like this, you know. Okay, so those are some key points. Now what we're going to do is we're going to take a look at how she responds in terms of her function, okay? Again, another independent parameter, an independent measurement that we can make on her. So that's what we're going to do now. So we're going to go over here, and we're going to do that right now, okay? All right, so here we go.
You get this solution for 200 milligrams per hour for 4 hours. And how long it takes to recover?
Immediately, almost.
Immediately.
It's like, this is a good, Alberto's asking an important question, so let me respond. Ketamine has a very rapid redistribution half-life, okay? So what does that mean in simple language? That means that when you turn the ketamine infusion off, it leaves the brain quickly, very quickly. So quickly it's like the patient, like she saw her, I turned it off and all of a sudden, boom, she's awake. Talking and so forth. Now let me tell you while we're on that, what are some common problems that can happen in terms of adverse things?
Yeah, perfect. Yeah,
One of the things you saw her salivate,
Yeah.
okay?
Yeah.
Especially in young people. You know, you've done kids with ketamine, you know, they just drool all over their face.
That happens very
So we have Robenal, what we call glycopyrrolate in the United States. You can give a little of that, 0.2 milligrams IV. Takes care of that, and it's important to take care of it because it's uncomfortable when patients are salivating all
Do you
over.
use it?
Of course. Because if I don't use it, they salivate, okay?
Yes.
And it comes down on the floor.
Yeah.
And then you start sliding all over it. The floor.
Not so.
in Alberta goes, Tony, you're exaggerating. A little bit. Un poquito.
No, I have been using ketamine for 40 years almost.
Yeah.
I know.
You know.
Yeah, yes.
Especially in young people.
Yes, especially.
Okay.
You have to use glycopyrrolate
You have to.
atropine. or
You have
something.
to, yeah. I prefer not atropine because it's cardiac.
No, I know.
Yeah. So, anyway, so what else can happen? Some people, women, you know how women are. Hey, Umberto, you know how women are, right?
Usually. Hormone dependent.
We got experience. And lots of experience.
Yes. Hormone dependence.
No, the thing is, when you look at women, no matter what you give them, they get nausea, they get queasy much easier than men do,
Yes,
right?
they do.
You take the bottle of ketamine, you just move it in front of them like that, and they get sick, The thought does it, Okay, so my point is this, is that, so nausea and vomiting is something that can happen. So you have, you keep making sure that they're hydrated, you make sure that if they are that way, you give them some prophylactic before. For example, you can give them Zofran orally an hour before they come in. 24 milligrams is a good dose, okay?
Okay.
All right, PO, okay? During infusion, what I found is a very good drug for nausea and vomiting. Drug's been around for decades. Dexamethasone.
Yes, I know.
It works fantastic.
Or droperidol.
Droperidol, yes. The problem with that is it causes other things, the brain and
Not the
crazy.
minimum dose.
Crazy. Yeah, minimum.
0.62.
But you don't get that with Zofran.
No.
But and you can get here in Cuba probably a reasonably priced.
No, we have suffering.
Yeah. So dexamethasone is not that expensive. Okay, so I recommend dexamethasone. Virtually no side effects. Okay, and what do I give in a situation like that? 12 milligrams IV push. Remember, I'm deviating a little bit. You know what's fascinating about dexamethasone? You know what's Decadron? You know what's fascinating? To me, it's fascinating. You give Decadron. If you give it too fast, you get pain in your groin. What the hell causes that? In the groin? I don't know. But it happens. So you tell the patient you may feel a little soreness down here if you give it too fast. Okay, all right. So now, the point I want to make is that we rarely ever have adverse. When Dr. Schwartzman, we started ketamine over a decade ago, using it for these patients. When we started using it, we had huge problems with adverse hallucinations. Patients were tearing out their IVs, yelling and screaming and doing all kinds of terrible things. We hardly ever see that anymore. No mas. Okay? All right. So that answers that question. But nausea, vomiting is something we see not so much in men, but in women. Okay? And it's treatable. The first day you pay attention, you see if it looks like it's going to be a problem, and you give them prophylactic before they come in. If they come and say, Doc, every time I get medicine I get sick, you give it to them before they come in. Okay, it's that simple. So those are the only two things you have to worry about when you give it like this, okay? Nausea, vomiting. If they have an adverse hallucination, which is extremely rare, give a little bit more midazolam, but try to stay away from midazolam. You give it at the beginning, no problem. But try to stay, because the more midazolam you give, the more they're going to slip into a deeper anesthesia, and you're not going to give them as much ketamine. Okay, all right. Let's move on to how she did after her treatment, okay?
Okay, Hannah, today is the 19th of January, and that means it's about 2 to 3 days after your last ketamine infusion, which was on Friday. And we just did your pain thresholds, and of course there was a dramatic improvement in your pain thresholds, okay? And what I'm going to do right from the very beginning here is going to kind of talk about how things went during the infusion itself, okay? So you were there, Dad, Mom was there, and the whole family practically there, didn't we?
Yes, sir.
And we did run into an issue in the beginning with some little queasiness and nausea. She has a history of migraine, so that doesn't surprise anybody, okay? But we were able to get it under control with giving her some Zofran before she came in, orally, and she had some Decadron during the procedure, as well as some glycopyrrolate, or Robenol, which keeps her from accumulating a lot of saliva, which can be extremely uncomfortable if you're under the influence of ketamine. But we got it under control. Would you agree with that?
Yes.
You didn't have any adverse hallucinations during the treatment, right?
Mm-hmm.
So that wasn't a problem. The one thing that limited us was you went too deep, and where you had difficulty answering questions, and we're going to go over that with you a little bit in more detail here in a minute, okay? But we got you up to 200 milligrams on the ketamine. Okay. So that's a very good dose. Are you ready to do some exercise to see what happened here with you?
Yes.
Okay, let's do the vertical finger test. Look straight ahead, don't look at me. Put your vertical fingers in your mouth. Are you having any pain when you do that? Remember, you had pain on the right side of your face, and on the left, worse on your left side of your face, and on your right side of your face. You don't have that now. Take that right hand, put it behind your head, please. Have any pain when you do that? Didn't have when we started, you don't have now. Now put the left hand behind your head. You didn't have any pain there when you started, now you still don't. Is that correct? Okay, take the right hand, put it out in front of you. Open and close it as fast as you can. Less stiff, huh? That's much faster, isn't it? Any pain when you do that?
No.
Didn't have any pain when you started, you don't have now. Right? You did have pain when you tried to do that with your left side. Go ahead and open and close as fast as you can. Much faster now, isn't it? And you still have that pain, remember, around your thumb and your finger? Don't have that now. Put both hands out in front of you. Open and close as fast as you can. Much faster now, huh? So what is it? You're going to start to play the piano? Is that what you're going to do? Huh? No? Okay.
Maybe.
Violin.
Violin, is that right?
She plays the violin.
Oh, is that right? Oh, before all this happened, she was doing that, huh?
Yes, sir.
Oh, that's interesting. Very interesting. Okay, now, next thing we're going to do here is we're going to ask you to roll up that pants leg on your left side there. And we have these marks on you where you had the allodynia. Now, there's a real sensitive skin that felt like road burn before we started. So I want to test that now to see if that's disappeared. So go ahead and start above that black mark, but close your eyes so you don't cheat. That's right. Light stroke and see if you still have any of that road burn sensation. Any of that down there anymore? Okay, and go down the other side there. There you go. All gone?
Yes.
Okay, very good. Excellent. Now the next thing I want you to do is I want you to rotate that right ankle for me, please. There you go. You know, less stiff there, isn't it? Have any pain when you do that?
No.
Now do the worst side, which is your left side. Go ahead, rotate. Any pain when you do that?
Not really.
No. Huh?
Not really.
Not really. And listen, while we're on that subject, remember we talked about the fact that you haven't been walking, you're out of shape, right? It's not your fault. That just happens to everybody that gets, especially in the lower extremity. And we're going to talk more about how to get rid of that, what we call muscle pain. That's not RSD pain. We're going to talk about that later. But you even notice how much better range of motion you have down there. You can move that foot a hell of a lot better than you did before. Look at your toes for us. All right. Can you hitchhike back to Plant City? Oh, look, she can do it. All right, very good, excellent. I'm going to stand by the door there. Dad's going to be by your side just as a safety precaution. Okay?
The color is better too.
Yeah. Well, it's even going to improve a lot more than it is right now with the exercise, okay? She's got to reestablish circulation down there in those legs, okay? Go ahead and take 3 steps forward, please. Just regular walking. That a girl. You're much more secure now, aren't you? Go on back, please. There you go. Remember, you had pain going all up to your hips when you did that before. What's going on now?
Not the same kind.
It's more that muscle pain just from being out of shape, right? Okay. And that's the kind of pain you can live with. You can't live with the pain that sucks the breath out, right? Yeah. It takes your breath away. No, you can't do that. Okay, now next thing I want you to do is you couldn't even do this before, but see if you can take 3 steps forward on your toes. Your dad's there if you need him for balance, okay? See if you can do that now. 1, 2, and 3. Very good. Good job. Now, did that give you the same pain you had before? No, I mean, is it the same
Oh,
pain?
no, not the same as the
Right. Now listen, we talked about another thing, didn't we? We talked about the fact that you've got to learn how to walk again. Remember, you have not been walking, okay?
Yes.
So it's going to take a while, like anybody, to pick that up again, how to walk, okay? Now, the next thing we're going to do is just, for completeness, going to ask you to see what you can do on your heels. Go ahead. 1, 2, and 3. That's good. And again, do you still have that pain you had before? Before we treated you? No. Okay, have a seat, please. All right, now, let's go over the treatment plan here. And again, if there's something you don't understand, you interrupt me and we'll get it clarified, okay? All right, now, we talked about the heated pull exercises 3 days a week, no more than 20 minutes each time. The water temperature should be between 82 and 86 degrees Fahrenheit. We talked about, getting yourself one of these little digital thermometers, you know, that you can use that will help you with gauging whether you should even get in the water. So if it's 80 or 81 degrees, you probably don't even want to go in the water that day, okay? All right. Now, the other thing we talked about, the 4 reasons why this works, okay? Reason 1 is you're not ready for full weight bearing. And in fact, it's kind of risky because you can fall and re-injure yourself, which is the most common reason why patients have a relapse, okay? Number 2, the water is a very, very potent desensitizer. So it'll even desensitize your skin so you can tolerate, you know, the touch better than you even now, okay? And the third thing we talked about is many times over and over again, you need to avoid exercises that can result in re-injury, okay? And water is an exercise you can do where you're least likely to re-injure yourself, okay? And the fourth thing we talked about is this. We talked about this thing called stress, right? And stress. Remember what we said about stress? Is it good or bad? Very good. You got your brain. How about that? She remembers. That's good. So your brain power. And by the way, while we're on that subject, let me tell you, you're probably going to find it a lot easier for you to focus now when you don't have so much pain, okay? So learning is going to be a much easier task for you, okay, going forward. That's right, it's neutral. What the heck is neutral? What is that? Well, stress is a biological response you can't control. And you can make it either a negative or a positive experience. And one of the things we've learned over the years is that there's one thing that always predictably works in controlling stress and keeping it from being negative. What's that called, Dad? What's that activity that we talked about that can keep the stress under control?
Physical activity.
There you go. Very good. I got the memory works well in the whole family here. Very good. By the way, he scored high. He's got the highest score from me so far. Okay, that's right. Physical. So water exercise is a physical activity and helps control the stress. So therefore, you're not going to get in a pool with a bunch of kids, are you? You're gonna where they're yelling and screaming and all that kind of stuff. Okay. Now, the next thing we talked about is medications. Now, you're not on any strong medications. We call those narcotics, like Vicodin, Percocet, and all that kind of stuff. But we did say there is a role for those in treating RSD, isn't there? If you get acute injury, like for example, you go to the dentist and he starts going in there and starts doing a lot of things in your mouth, you can't handle the stress like the pain from that as other people can, and it can set off the RSD, right?
Yes.
Okay. Now let's turn over to the parents here. You've been with her over the weekend. What do you think? Has her mood improved? Is she seeing a little bit more hopeful? Dad, we'll start with you.
Yes, sir. She's improved a lot. I mean, her mood, her attitude has changed a lot over the weekend. She's been able to do activities over the weekend that she hasn't been able to do in a year and a half. Good. And we know, and we're optimistic about it, and know that they're just going to continue to get better with physical treatment and physical exercise, and just really look forward to it. I'm so happy that she's doing good.
Right. Now, did you have any questions?
No, sir.
Okay. And Mom, do you have any? Do you kind of agree with all that?
Yes.
Yeah.
And she's really enjoying taking a bath now. The water doesn't feel like razor blades. So
right. Well, I'm glad you brought that up, because being able to take care of yourself and hygiene and all that kind of stuff is really, really important. Okay. Even eating. Remember, she had a lot of jaw pain before.
Right.
Mm-hmm.
So she can enjoy eating now, which she couldn't do before. Mom, do you have any questions?
No.
Okay. Now let's go back over here to Hannah. Hannah, did you have anything to add to what your mom and dad said about the experience?
No.
Okay. How about you? Do you have any questions? Now, I have a question for everybody here. Now, we always try to learn from experience and share that with others. Are all of you comfortable with using this recording? And of course, she's going to be back in about a month or two, and we're going to repeat all this. Are all of you comfortable with the idea of sharing this information with others out there? They can learn from your experience. Is that okay with you, Hannah? Let's make sure it's okay with your parents. Is that okay with you?
Yes.
Absolutely.
Yes, sir. Just want to make sure. Okay.
Okay, what I want to do now is I want to summarize for you what we call the take-home message, okay? I wanted you to see the video. I wanted you to see the pain thresholds. I wanted to test both of you so you can appreciate the precision of the measurement, reproducibility of the measurement, so that you could see that the focus here is on objective measurements. So you as a doctor can feel confident that you're helping the patient and you're not harming them, especially when you're doing something new. This is new. This didn't exist, and it's still being evolved in the United States right now. I have doctors coming to us. We're a nonprofit, or they come to us to learn how to do this properly. And if you don't do it properly, it will not succeed. But the most important thing I want you to get from this discussion today, informal, first acquaintance and so forth, is the idea of objective measurements and how important that is. Not just for you, but for the patient as well. Okay?